Okay, folks, so you exam right? Everybody wants it on Wednesday rather than Monday. Yes? Yes. Monday. We'll do it Wednesday then, but it will only cover, the Monday lecture will not be on the exam. We'll be trying to test you a day later, on the materials went over. So it'll be up to including today's lecture. If for some reason you really desperately want it on Monday, one or two of you, or you can't make the Wednesday for some reason, whatever, let me know. You can take it sometime, other than the Wednesday, the Tuesday, or the Thursday, or the Monday, whatever. Okay? So there's two major topics we've got to finish this semester. It's going to be cerebral blood flow and autonomic nervous system. It's going to a chunk of time going over those two things. So if you're reading ahead, one of you, was it two of you doing that? Is that right? The next topic after we talk about these motor symptoms and pathways is going to be cerebral blood flow. There's a nice chapter in the book, in the text, on cerebral blood flow. So if you over Easter you want to read something, read cerebral blood flow. But before we get to that, we're going to go over some diseases, some common diseases you'll find in the motor pathways. And what I mean by the motor pathways here, we have our upper motor neurons. Okay? Upper motor neurons, within the upper motor neurons, you can look at the pyramidal pathways, or sometimes called the corticospinal pathways. Cortex to spine, obviously, for our control of our skeletal muscles. We have corticobulbar pathways, motor cortex to the brainstem for control of facial and neck muscles, the cranial nerves in essence. Okay, that's the corticobulbar tract. There's some diseases that like to affect that. There's some diseases that like to affect the corticospinal tract. And we also have the extrapyramidal pathways, which are also upper motor neurons, but they don't come directly from the cortex. They're influenced by the cortex, but a lot of those pathways are much more primitive. The reticular, vestibular, etc. pathways, they start at subcortical levels, like the basal ganglia. They go down the core and do things too. Okay? So if we get damage to, for example, the basal ganglia, they will affect those extrapyramidal pathways, and you get your Parkinson's symptoms and your careers, etc. Okay? So we all know the difference between an upper and lower motor neuron, don't we? Lower motor neurons are not motor neurons that go to the lower part of the body. Lower motor neurons go to my little finger as well. Lower motor neurons are neurons that start within the spinal cord in the ventral grey horn. That's where the cell body is. They're multipolar neurons, and they go out to the muscle, throughout the body. Simple as that. Those are lower motor neurons. They're not part of the central nervous system per se, even though they start within the central nervous system. In other words, they start within the spinal cord, right, in the ventral grey horn. Because you've got so many nerves going to our legs and arms, you'll find a cervical enlargement in the cord and a lumbar enlargement in the cord, aren't there? So the cord swells in two places. The cervical and the lumbar area called the cervical enlargement and lumbar enlargement, because within that enlargement we have tons and tons and tons, millions of these alpha, beta, gamma motor neurons starting the ventral grey horn going to our muscles. We haven't got as many muscles in the trunk as we have in the hand and the arm. So we need more space within the cord to start those neurons. That's why you get a cervical enlargement and a lumbar enlargement. Fair enough? So those are our lower motor neurons coming out of the cord, going to our muscles throughout the body. Upper motor neurons, of course, are the motor neurons within the central nervous system that start in the cortex and go to the spine, cortical spine, or start in the cortex and go to the brainstem, corticobulbar, or start at the basal ganglia and go to the spine. Those are all upper motor neurons. Okay? So if you damage any of those, you're going to get upper motor neuron symptoms below the level of damage. Okay? And usually most symptoms will be ipsilateral to that damage, obviously. Because most of our corticospinal neurons, of course, cross over at the decussation of pyramidal medulla. So if you have a lesion above that decussation, for example, in the internal capsule on the right-hand side, you're going to affect the left-hand side of the body. Okay? If you get a lesion in the cord, so basically after you pass the decussation, basically you're in the cord. That's at the bottom of the medulla, this decussation. So as soon as you get out of that decussation and you're into your lateral and ventral spinal, corticospinal tracts, you're in the cord now. So if I was a lesion in the cord and I affect the lateral corticospinal tract, you're going to have ipsilateral symptoms. Because the lateral corticospinal tract is going down the left-hand side to go to the left muscles. Okay? You would have less profound, well, you should have very profound influences, but if I had a lesion in my right internal capsule, I affect both the anterior and lateral corticospinal tracts, don't I? Okay, so everything to the other side of the body is gone. I'm making these very black and white, but but if we, let's say we lesion the lateral corticospinal tract in the cord, remember about 85% of the neurons that come out of the internal capsule cross to make the lateral corticospinal tract. Around about 15% stay ipsilaterally as the anterior corticospinal tract. So if I lost my lateral corticospinal tract, I still have my anterior corticospinal tract going down the opposite side of the cord, then most of those neurons are going to cross back to that segment level, at the segment level to the other side. So you have some function. It will be very good. Okay? 5% of those 15% in the anterior corticospinal tract do not go back to the other side. They stay ipsilaterally. Okay. I'm making it very black and white. You're not going to have somebody have a perfect cut in the lateral corticospinal tract. The symptoms are going to be based on the size and the amount of the lesion, how severe that lesion is to these tracts. Okay, you're not typically you won't get every single neuron sliced, unless it's like a trauma for a gunshot or something like that. Okay, we all know the difference between upper and lower motor neuron symptoms. You're guaranteed to get questions on those in the exam, in your board exam. Okay, don't confuse hyperreflexia with hypertonia or whatever. Okay, make sure you know what comes out of a upper motor neuron, lower motor neuron. The corticospinal tracts, we said, started at layer 5 in the cerebral cortex. Most of these are coming out of the motor cortex. Some of our corticospinal tract neurons actually come out of the sensory cortex. And very few do. Some actually come out of the prefrontal cortex, in front of the motor cortex. So not every neuron that goes into the corticospinal tract comes out of the motor cortex. But the majority do. But there are, let's say, some coming out of the prefrontal cortex. And they all join together to get out of the brain via this internal capsule. Okay? Which is this sort of bottleneck between the thalamus and the basal ganglia. That's a frontal plane view. This is a transverse plane view on the bottom there. And you can see that it's a shape like a leg, as it were, with an upper leg, a knee, and a lower leg. Okay? And those are labeled anterior limb, genu as the knee, and posterior limb as the lower leg. Okay? The anterior limb, we won't talk much, because tracks go through there, but not looking at descending tracks to the cord there, so we're going to forget about those for now. But our motor tracks come down the posterior limb. And they're somatopically organized, body map, in that the face is close to the knee, the genu, the angle of this anterior capsule, then the arms, and then the legs. FAL, like that. So, depending on which part of the internal capsule you damage certain parts of neurons going to whatever part of the body. The FAL at the back of there, again, is in the small letters, that corresponds to the sensory fibers coming up. Okay, so the very posterior of the posterior limb, we find sensory tracts coming up into the brain. There are some small arteries. We'll talk a lot more detail when we look at our cerebral blood flow. The striate arteries, there's types of these, but these are very small arteries that branch off bigger arteries like the middle cerebral. These striate arteries supply various parts of the internal capsule and other things as well. These arteries are sometimes called, nicknamed, the arteries of stroke. Okay, they're small arteries some of the first small arteries that lead off major arteries like the carotids and etc. And they're very strong to stroke. A bit of plaque breaks off the heart, it comes floating down a big, nice artery. First thing it comes to the striate artery, clogs it. I have an internal capsule stroke, and then you're in a mess. Okay. Much rather have a stroke in the motor cortex than the internal capsule, because the internal capsule contains all those neurons that are leading out of the brain. Okay, makes sense? So, let's look at some common garden diseases, lesions, whatever, that are going to affect these motor pathways. Either lower motor neuron, we've mentioned a few before, and the upper motor neurons. What's the most common demyelinating neuron disease in the peripheral nervous system? What will affect the lower motor neurons? This one? Guillain-Barré. What's the most common demyelinating neuron in the upper motor neurons? MS. Okay, so we can talk about those. Let's mention, we're going to go through a few of these, see which part of the motor system they attack, and what the signs and symptoms they are. Okay, poliomyelitis. And polio means, polios is Greek for grey, and myelos is the marrow, the middle of something. Polio, hopefully you won't see any with polio, because it's basically been eradicated in most westernized countries. If you travel around, and we've had students who go on missions that were doing rehab in Belize and places like this. Polio is still evident in Afghanistan, in India, some place in Africa, Nigeria, for example, Pakistan. So these kids are still getting it because they haven't been vaccinated against polio. It's quite easy to do it, but it's not getting done for whatever reason. So polio is caused by a virus that invades the system, or the vector that gets this virus into your system is either through an insect bite or GI tract. You eat the stuff, basically. You get into the stomach, this virus. And it spreads via the blood from the GI system or from the skin into the nervous system. And what it likes to do initially is attacks the ventral grey horn. It eats cells, it destroys cells in the grey horn, particularly the lumbar and cervical enlargements. So is that a lower motor neuron or upper motor neuron? It's attacking the ventral grey horn within the cord.
Lower motor neuron?
Lower or upper? Lower. Everybody agree it's lower. It's in the central nervous system, but basically it's the start of the lower motor neurons coming out of central nervous system. So you're going to see lower motor neuron symptoms like loss of somatic reflexes, areflexia, weak muscles essentially. Because it's a virus, you're going to see other issues like a patient would present with a very severe headache, fever, pain. It's often was confused with meningitis and diphtheria. But it's a lower motor neuron disease. It used to be called infant paralysis because it attacks the kids. Infant paralysis. Very, very widespread in America in the 40s. Very widespread. So what happens is basically it attacks the lower motor neurons. You get these symptoms developing for a few weeks. They get worse. The patient gets worse and worse and worse. Then it plateaus. And then they start to improve, regain some function. Okay? And the fever breaks, and you're basically left with these motor symptoms that last basically the rest of your life, I think. Hopefully you have some recovery. The kids could die if it invades the brainstem. If you start to get into those lower motor neurons, supply the heart, the lungs, breathing, the kid can die. Okay? Recovery takes weeks and weeks and weeks and weeks. People get stronger, maybe even a year or so. People are still getting a bit, returning some function. And then basically you're done after a few years of rehab, looking at strength and exercise, etc., etc. But you're basically left with, severe extremity problems. Fortunately, you don't see it in America or in any westernized country now. Because of what? Who came up with the first vaccine? Jonas Salk, right? 1952, he came up with a vaccine, which is an injection. You've heard of the Salk vaccine, S-A-L-K, yes? No? Jonas Salk was a bloke who saved, thousands and thousands and thousands and thousands of kids by coming up with this vaccine, which was an injection. Okay? It didn't protect you against the ingestion of the virus, so Sabin came up with a better idea in 1957, licensed in 1962, I think. This is like a sugar drop you take, a sugar pill, and that's the vaccine on there, and it protects the GI system as well. So fortunately, it's eradicated in America. You will not see a patient 99.99% of the time with polio in America. You will, though, see something that looks like polio. That the patient who had polio thinks they've got polio again. And that's called post-polio syndrome. I've seen patients with post-polio syndrome. If the patient doesn't know what's going on, they come in scared because they think polio has come back and they're getting worse. So they'll come in complaining of the same, not the fevers, but they'll complain of weaknesses. And their muscles are weak and fatigue again, and they think, oh my God, polio's re-emerged, as it were. Trigger point, I find the couple of patients I've had very bad trigger points, pain. The one guy I remember I was treating him over at Eastern Maine on Union Street, outpatient. He was a surgeon at the hospital. And he's in Lochran crutches, and he said he said it was in his scalenes, massive pain in his scalenes, but when I massaged and palpated, it was actually in his SCM. A massive trigger point in the SCM. It was massively painful, and he couldn't function. And so we did trigger point massage on him. And I was really getting in there, and he was screaming, but he was in agony. And I was supposed to see him 2 days later, and he never came back. So, oh my God, I've hurt him so much, he's never coming back. But he actually came to the class and PTs with Sondra's class and gave a talk on post-polio, and he said, oh, thanks Ben, that was brilliant, exactly what I needed. Kind of got rid of this trigger point in his neck, just by mashing on it, basically. He'd get it every year or so, these would come back to him. So anyway, these people come back with what's known now as post-polio syndrome. So the theory here, what's happening is, these people, 30 or 40 years after that polio, this new muscle weakness emerges. And what the theory is, why it emerges, because when you're recovering from polio, so what polio has done is eaten some of the alpha motor neurons, let's say, going to my biceps. So a certain percent of my alpha motor neurons in the ventral gray horn going to my biceps have been killed by polio. Okay? So the other motor neurons that were not eaten, destroyed by polio, realize, oh, look at all that muscle cell over there. There's no neuron going to it anymore. It's de-innervated. So they sprout. The remaining motor neurons, alpha motor neurons, sprout and go over there and innervate that muscle that's been de-innervated. They try to make up for their buddies who've been killed. They go over there and innervate muscle that's not being innervated because the polio has destroyed those alpha motor neurons going to that chunk of muscle over there. So they re-innervate the muscle as much as they can. And that's why you get stronger. That's how you recover from polio. But what happens, as this theory says, is that after a while, 30 odd years later, those motor neurons that have taken on double duty basically have burned out and are sick of it. They can't handle anymore. And they die back. They die back to their original innervation ratios. And therefore the muscle gets weaker again. And that's the thought of how post-polio syndrome arises. And you will see, I mean, if you work in a clinic for a while, you will see post-polio patients. This is in the 50s, and that's when it kind of eradicated. You might see some of these patients still coming into the clinic. Okay, let's look at the next one. You're obviously in other classes, you're going to go over these in way more detail. I'm just introducing the basics of these. Cerebral palsy. It's a catch-all term. Cerebral palsy is a catch-all term for any kind of brain damage to young kids. In essence, it's a very, very broad category. It's basically a lesion in the motor cortex, the corticospinal tracts, basal ganglia, cerebellum. You see lesions usually acquired during birth, blood deprivation during birth perhaps. There's many causes of it, some completely unknown. Occasionally there's a definite cause. We know this happened during childbirth. We know that the mother had measles or contracted rubella and the kid got rubella through the placenta. This is what gave the kid cerebral palsy. But in many cases we don't know why it occurs. We had a case from the 60s, yesterday I was talking about a little kid unfortunately got shaken baby syndrome at 4 months old. And Dad shook the boy and he went to hospital and they put the kid back with the parents. The father shook him at 7 months old. Again, the kid now is taken away and is in foster care, but he's got severe epilepsy and cerebral palsy. In a stander, and a walker, completely dependent. For feeding a peg tube, can't speak, etc., etc., using a communicator to try and speak. But that was based on an acquired brain injury at 4 months old. And that's he had cerebral palsy. Most of the times we don't know why it comes, unfortunately. And because it's a catch-all phrase, cerebral palsy, there's a variety of places within the central nervous system that can be damaged, and therefore there are a variety of symptoms you'll see in a patient, depending on where the lesion is. You might have paralysis, you might have deafness, there might be blindness. Often spasticity is going to be present. It can affect the upper motor neurons largely. Gait, posture, whatever. A whole gamut of symptoms that we have a central nervous system damage. You can see anything, basically. It can be severe, it can be moderate, it can be mild, whatever. And you obviously treat what you see. If the child's legs are affected only, you're going to call it diplegia, spastic diplegia, very common. It's one of the more common types of it, perhaps. I know in In motor control, we talked about, a spastic diplegic child will walk on his tiptoes. Have you seen a spastic diplegic kid walking like this, bouncing on their feet because they've got contracted legs? That's a typical spastic diplegia child. You can have quadriplegia. You can have all four limbs. You can have hemiplegia. That's one-sided. Both sides, leg and arm on one side can be affected. It depends where the lesions are and how widespread, and You can also break cerebral palsy into the type of symptoms you'll see. So you'll see athetoid cerebral palsy. Are you familiar with that term, athetosis, athetoid? I've got a little video later where we'll look at athetoid. Athetosis is this bizarre writhing of the hands and arms, so like this kind of thing. Okay, that's athetosis, and that if a kid has those symptoms are prevalent, they'll be called athetoid CP. You can have taxic CP. I had a little girl in East Main a while ago, Maddie, who had ataxic CP. She walked like she was drunk. She couldn't walk smoothly at all. That would be ataxic CP. You can have hypotonic CP. Obviously, very floppy muscles. Sometimes they're called mixed. In other words, mixed CP. They've got a variety of these symptoms, and not one or the other. And again, it's always going to depend on where the lesion is and the severity of the lesion and what part of the brain it's affected. And you'll see this variety of types of CP. Some kids are high functioning. Some kids, like this kid yesterday we're talking about, very, very, very low function. You have to do everything for the child. He's in school, but it's very difficult to deal with the child. Enormous amount of money to take care of some of these kids. And in Sandra's class, I know in PT, in Suzanne's class, we talk a lot more about CP, assessment and treatment. I'm sure in OT you have a whole section on, in how to help children with CP. Next one, let's quickly work through these. ALS, amyotrophic lateral sclerosis, or Lou Gehrig disease. Named after Lou Gehrig, who died in 1941. Was he a Yankee? I don't know if he was baseball. Yankees. He died at the age of 38. In a lifetime batting average of like 0.35 or 350, I don't know. 0.35, that he said? Whatever. He was a very good player. And he died of ALS, and often it's called sort of Lou Gehrig disease. What does ALS stand for? Amyo, without, myo, muscle, trophic, nutrition, lateral, meaning the lateral corticospinal tract is gone, damaged, sclerosis, scarring. So you've got without, muscle, nutrition, lateral scarring. So this disease attacks, initially anyway, predominantly our lateral corticospinal tract. Okay, it's a chronic degenerative disease that gradually gets worse. No idea why, of course, unfortunately. It's no known cure, no known cause, unfortunately. It usually starts off in the mid-cord, usually, starting attacking those neurons. But it attacks, as I said, selectively the lateral corticospinal tract, and then sometimes it will attack the lower motor neurons at those ventral grey horns. So you can get a mixture of upper and lower motor neurons. Predominantly, usually it's upper motor neuron symptoms you'll see. You'll see spasticity. You might see muscle atrophy and weakness, though, if it's got those lower motor neurons in the cord. One of the first things you'll typically see will be hyperreflexia of the forearm and the wrist and the fingers. Hyperspasticity, as it were, of the forearm, wrist flexors, fingers, the forearm. It gets worse and worse and worse, and eventually it will affect breathing. If it migrates upwards into the brainstem, you've got your breathing, your swallowing issues, feeding issues, all that kind of stuff. And eventually they'll be in a wheelchair and die. It's usually pretty fatal. A lot of people will die in a few years after getting this. A few years, maybe 5 years.
Is there an age group that's like more at risk?
Yeah, it's more middle age, sort of 40 to 50 years old is when it will typically start. Most often it's going to start. And more men than women.
Does it ever start like in the 20s ever?
It can, but that's rare. What, do you know someone who's had it at 20s?
No, I was just curious.
No, I mean it can, but most cases are going to be 40 years, 50 years, something around there. A lot of people die in a few years after getting this. It progresses and affects their breathing, eating, swallowing, respiratory distress, they'll die. But I think 10% of people who get ALS survive longer than 10 years. Some people can last a long time with it. Like Stephen Hawking, right? Supposedly the most intelligent bloke in the world, whatever. Oxford University professor. He's in a wheelchair now, obviously. He wrote, the Brief History of Time, or History of the Universe. He's a physicist, and he writes about black holes and all this stuff. So, this proves cognitively they're perfectly okay. There's nothing wrong cognitively with these people, which is, terrible. Their brain is completely normal. They just can't move their body. He's in a powered wheelchair. He has a computerized voice synthesizer to talk. He writes his books that way. He writes all these fantastic, books on physics, on the black hole. So he's completely cognitive there, but his motor system is just messed up terribly. So it's thought, if you get it earlier in life, then you last, the progression is slower, and you last longer. If you get later, in the 50s or 60s, you die, sort of the progress or processes accelerate and you die earlier. It's a nasty thing to get. Fortunately, it's fairly rare, 1 in, I think, 50,000. Again, we don't know why. We don't know where it comes from. There was an interesting case in 1964 in a San Francisco football team. 3 people had it. 3 people in one football team developed ALS all of a sudden, which suggests what? Environmental. Some of those people had went to some place together and somehow got it, but no idea why, how. But that suggested an environmental kind of cause to the thing. There's an interesting sort of cell of ALS in Guam. Remember that Pacific Island, the American protectorate in Guam, and it's actually they call it Guamanian type ALS, because it was 1 in 10 people on this island got. It was 1 in 10 and 1 in 100. I can't remember. Very common anyway, extremely common. I think it was 1 in 100. 1 in 100 people got ALS in Guam. Amazing percentage. 1% of everybody in Guam got ALS. And what they found is that a lot of volcanic minerals in their diet and in their brain. But in autopsy they found a lot of volcanic minerals, it's a volcanic island, in these patients. Now with improved diet, improved water system, it's about 1 in 1,000. But it's a weird sort of type of ALS they found in Guam, and they think it's obviously something environmental, they think, in that place. You can see these plaques with MRIs, and they'll do EMG studies, and it's quite easy to diagnose. There's one thing they'll take. Riluzole is a drug that tried to slow the progression, has some success in slowing the progression of ALS. This is a glutamate antagonist. Remember, glutamate is a very, very prevalent neurotransmitter throughout the nervous system, and this has been found to slow the progression of ALS. But OT is going to be very, very important in adaptive equipment for these people. You can't cure it. They're going to get worse. So toileting, feeding, speech, all those issues, wheelchair, transfers, adaptive equipment to make their life, livable is the way you're going to go with these people. Cortical bulbar tract. Let's just quickly review that, add a little bit more detail before we talk about myasthenia gravis. That is a disease that likes to attack the cortical bulbar tract. Remember, the cortical bulbar tract is basically upper motor neurons coming from the motor cortex to the brainstem. Okay? It's not going to go to all cranial nerves. Why not? I don't want motor nerves going to my retina. You can't contract your retina. Okay? So what three nerves would you not have motor fibers within? Cranial nerves. Optic, olfactory, and vestibulocochlear. There's no muscle in your nose. Olfactory bulb, anyway. Okay? When you twitch your nose, it's not the it's a facial nerve, not the olfactory nerve. So these sensory nerves obviously are not supplied by the cortical bulbar tract. The rest are. Okay? Now, this is slightly different from the corticospinal tract. The corticospinal tract, left-hand side of the brain, supplies right-hand side of the body. The cortical bulbar tract, you can see from this kind of representation. Remember these grey dots here represent the cranial nerve nuclei. These are the start of our motor neurons going to the muscles, of the alpha motor neurons. These are analogous to our ventral grey horn here. Okay? So, you can see from this diagram, unlike the corticospinal tract, the corticobulbar tract is a bilateral tract. Most of it is. In other words, you can see in this diagram, the right hemisphere innervates both the left and the right cranial nerve nuclei. Okay? Except in two nerves. The hypoglossal, if you look at the very bottom of the diagram here, the hypoglossal only receives a contralateral supply, just like the body does, just like the corticospinal tract. That's normal for the body, it's abnormal for the corticobulbar tract. So the hypoglossal, the tongue muscles, are supplied contralaterally only. Right hemisphere, left side of the tongue. Left hemisphere, right side of the tongue. That's what we find in the corticospinal tract. That's unusual in the corticobulbar tract. Okay? The only other one that's kind of weird, of course, we've come across this before, is the facial nerve, the facial nuclei. Remember, the lower face has a contralateral supply. The upper face muscles have a bilateral supply. In other words, they get supplied by both cortices, left and right. Okay? So you can see the rest of them, the abducens, trochlear, oculomotor, blah, 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 all have a bilateral supply, which is very nice. Because if I have a stroke in my left cortex, my right cortex is going to supply those cranial nerves on both sides. So a stroke won't affect the cranial nerves as much as the extremities. The face, of course, the lower face, remember, is the place where you have this contralateral supply only. But if you have a stroke in the right hemisphere, you're not going to lose your left abducens, or your left trochlea, or your left oculomotor, etc., left glossopharyngeal, etc., etc., because the right hemisphere is also supplying it. It's a nice redundant backup system for that cranial nerves. Okay? That makes sense. So your strokes, your unilateral strokes in the hemisphere, in the motor cortex, are not going to have as powerful influence, fortunately, on our cranial nerves as they will on the arms and the legs. Okay, my left arm does not get a supply from my left cortex. It gets a supply from my right cortex. I lose my right cortex, I lose my left arm. I don't lose my left trochlear nerve because I'm getting supply from my left trochlear cortex and left cortex. Make sense? It's an important distinction between the corticobulbar and corticospinal tracts. Remember, your lungo has a contralateral supply and your lower face has contralateral supply only. Okay. One of the things you'll find, one of the most common problems, well, in the corticobulbar tract or in the facial muscles, is two things: Bell's palsy, myasthenia gravis. We talk a lot about Bell's palsy. We initially only introduced myasthenia gravis. Let's talk a little bit more about myasthenia gravis. My muscle, asthenia, weakness, gravis, grave. Severe muscle weakness, it means. This can affect any muscle in the body, but it likes to attack initially our cranial, our corticobulbar, the muscles supplied by our cranial nerves. Any muscle supplied by the cranial nerves, it likes to attack those first. So your face, your lips, your tongue, your throat, your neck. Those muscles, eye muscles, etc., are going to be attacked before it attacks your leg muscles, typically. Characteristic symptoms. Does anybody know anybody with MS? Myasthenia gravis? No? You've seen people with myasthenia gravis on field work? It's not uncommon. It's more common in females than males. Roughly 20 to 50-year-olds, that's rare, sort of a young adult, middle-aged, kind of 20, 50-year-olds, that's when it usually shows up. Easy to spot. You'll see a patient's face droop late in the day. This is typically bilateral, whereas remember Bell's palsy is typically unilateral. So you'll see ptosis. There's the easiest one to see often. Ptosis. The eyelids get heavy at the end of the day, and they'll droop. The face droops at the end of the day. Fatigue. They have difficult chewing, swallowing, because this is all cranial nerve stuff. You might see strabismus, because our oculomotors, our abducens, and our trochlear nerves, those muscles in those eyes are going to be affected. Diplopia, double vision, affecting your eyeball movement. These patients can get remissions, can go, but generally it's a progressive relapsing disease. They gradually get worse and worse and worse with time. Death comes when it invades the vagal nerve and respiratory muscles. So if it's affecting your heart and your breathing, the patient can die. Where it comes from, I have no idea. Unknown etiology, unfortunately. You do a autopsy on somebody's nervous system, you don't see anything. No changes. You do an autopsy on a patient with stroke, you see a change. Autopsy on a person with Parkinson's disease, you can see a difference in the brain. You do not see differences in a myasthenia gravis patient with a brain dissection. Brain central nervous system looks just normal. Sometimes you'll see the thymus gland an abnormal thymus gland. So some surgeons will whip that out. They'll take the thymus gland out of the patient. Maybe that might help. We do, though, see changes in these muscles. If we go and look at the muscles, not the nervous system, we go and look at the patient's muscles, we'll see changes in it. And we find antibodies. So we thought it's some kind of autoimmune disease. Some people say it's a metabolic disorder, but most people think it's autoimmune disease. Not sure how. But we find antibodies at the neuromuscular junction. Okay? And there's two types of antibodies. One will block the calcium channels that cause release of acetylcholine from those alpha motor neurons. So you're blocking the release of acetylcholine into the neuromuscular junction, into the motor end plate. So the motor neurons trying to cause my facial muscles to contract. Acetylcholine is hard to release the stuff. So it's much less effect. The second antibody, unfortunately, you'll find on the receptor sites for acetylcholine. So the receptor sites in the muscle itself that want to get hold of, want to grab acetylcholine, are blocked. So you have weakness. You cannot contract the muscle is weak. So the action of these antibodies are very similar to curare, which is that South American glow dart poison, remember? And snake venom. Snake venom, you get bit by a snake, it does the same thing as myasthenia gravis. It blocks the acetylcholine receptors permanently. That's why you want to get a monkey out of a tree. You shoot a blow dart at it, and it blocks the muscles contracting, holding the monkey into the tree, and it falls out, and the respiratory system is gone, and you've got your dinner. Okay. There's actually a lot of research done with snake venom on myasthenia gravis. They use bungarotoxin, which is cobra venom, to quantify the severity of the disease. That's cobra venom. And what they'll do, cobra venom binds irreversibly to acetylcholine receptors. Okay? So what they'll do to find the severity of this, so let's just make a schematic. Here's a chunk of a person. They'll do a biopsy. They'll do a biopsy or take a chunk of little muscle out of the person with a needle and look at that muscle. Okay? These, let's pretend those are my ACH receptors sitting there. Okay, normal muscle, fine. So I will now pour a known quantity of bungarotoxin over this muscle, which wants to bind to ACH receptors. Okay, so I pour it all over here, and lo and behold, it binds, it blocks all those receptors. And I measure how much comes out the bottom. Let's make up something. Let's pretend I put 100 units in, and nothing comes out the bottom. In other words, I've got perfectly normal muscle because all those acetylcholine receptors are available, the bungarotoxin binds them, nothing comes out the bottom of my experiment. Fair enough. Now I've got this muscle that has got myasthenia gravis. So here's my muscle with myasthenia gravis. Here's my acetylcholine receptors. And lo and behold, a chunk of those are already bound by the myasthenia gravis antibodies. They're not available. They're permanently bound by myasthenia gravis antibodies. So then I pour my bucket of bungarotoxin over this muscle, and lo and behold, a lot of it comes out the bottom. Because there's nowhere for it to bind. Not as many sites. Does that make sense? And you can quantify how many of these sites are bound by mg by how much comes out the bottom of my little experiment sort of thing. Does that make any sense? So myasthenia gravis usually will bind only about a third of normal. Okay? So if I put 100 units of bungalow toxin into this muscle, 66 will come out. Normally 100 will stay in because all those receptor sites are available. But they've got these antibodies on it. So I'll get 2/3 of it come back to me out of an experiment because the sites are already bound by these antibodies. Does that make sense? How you can quantify the severity of what percent of these receptors are bound, affected by myasthenia gravis by using this cobra venom. Okay? So when you're walking through the jungle and you get hit by curare and you know, oh, that's my alpha acetylcholine receptors are getting attacked and I'm going to fall out the tree. What do we do for these patients? Of course, all our modalities, we can do a lot of treatment, a lot of adaptive equipment for these people as the disease gets worse and worse. What's a pharmacological choice? What's the thing we talked about at the beginning of the semester?
Neostigmine?
Yeah, neostigmine. Remember that one, neostigmine? It's a cholinesterase inhibitor. A cholinesterase inhibitor. Remember that cholinesterase breaks down acetylcholine in the synaptic cleft. Okay? So what we do by giving them this stuff is allows that acetylcholine to hang out in that synaptic cleft longer. It has more chance of finding the 1 or 2 available receptors on the muscle. If I pump it out and put it back in very quickly, I have less chance of finding any available receptors. So you want to give them this. Sometimes they'll carry an injectable pen of this. If they're going respiratory distress, they'll stab themselves with this stuff. Okay, to allow them to continue to breathe. Eventually, patients will be on a soft diet and all that kind of stuff. We notice again as they get worse and worse. These patients, a lot of adaptive equipment for these people. There's one other thing sometimes they'll try. They try plasmapheresis. This is where you basically take the plasma out of somebody and filter it. You try to filter the antibodies out of the patient. It can help sometimes. That's one disease that likes to attack the corticobulbar system. Well, the muscle is innervated by the corticobulbar system anyway. Let's look at the extrapyramidal pathways. So remember we talked about rubospinal, reticulospinal, vestibulospinal, and tectospinal. These are extrapyramidal pathways, are older pathways, less advanced, more reflexive, more subconscious, and they're not as easily crossed or uncrossed as the corticospinal. For example, we looked at the vestibulospinal tract. Remember, we've got the lateral vestibulospinal tract. It's unilateral, uncrossed. The medial vestibulospinal tract is a bilateral tract, a crossed and uncrossed fibers. This is an older pathway, starting influenced a lot by the basal ganglia. Okay? Many interconnections within the basal ganglia, within the nuclei of the basal ganglia, influenced by the motor cortex, influenced by the cerebellum, eventually leading to these 4 major, there were other ones as well, but these are major extrapyramidal pathways. Let's skip that one. Remember this diagram. This is the direct and indirect pathways through the basal ganglia. And I said, Slide will require to memorize all these pathways, but basically the key gist of this is this direct pathway here to the supplementary motor area is an excitatory tract, whereas the indirect pathway around here to the globus pilaris external and subthalamus nucleus is an inhibitory tract. So these feedback loops going through the basal ganglia are trying to influence the supplementary motor area. And the supplementary motor area is one of the areas that gives us the cue to move. drives us, motivates, gets us going, etc. So the battle between these two tracks and the effect of remember substantia nigra, remember that? This is the black substance. This is the thing that decays, dies off, atrophies, produces that dopamine, and therefore the imbalanced neurotransmitters going through these basal ganglia circuitry. Okay? And that's when we get our diseases. Our patterns and signs and symptoms of the diseases are based on the effect of these pathways on our motor system via the extrapyramidal pathways. And we have positive and negative symptoms, remember. Positive symptom is something that comes out that you wouldn't normally see in a person. Negative symptom is something they can't do that they normally could do. Parkinson's, we'll come to it in a second, first named after a bloke, Dr. James Parkinson in 19th century, an English bloke, an English physician, who wrote a very famous paper that's called The Essay on Shaking Poles. He was the first person to say this is a specific diagnosis here. It was named after him, Parkinson, James Parkinson. Very, very common, right? Most people seeing someone with Parkinson's disease, on TV at least anyway, right? I think 1% of the population of the world over the age of 60 has Parkinson's disease. 1% of everybody over 60 in the whole world has Parkinson's disease. 100. So you're going to see this. You're going to see a lot of patients with Parkinson's disease. I've seen, quite a few. I think it's like 50,000 new cases in America a year, something like that. A lot. And depending where you live, you will see more or less Parkinson's disease. It's weird. There's certain places where it's very prevalent, more prevalent than normal. The Amish or Amish community, right? That's one of the highest incidents of Parkinson's in the world. People who from the Amish communities, or Amish, you pronounce Amish or Amish? Amish. I think they say Amish. Whatever. Then I used to work with them in Pennsylvania, a big community in Pennsylvania, and they said Amish, I think. Whatever. You know how to spell it, don't you? I think 1% of the whole population, not mind over the age of 60, has Parkinson's disease. Very prevalent in the Amish community. Nobody knows why. Some people think it's due to the pesticides they use. They're a very agricultural dominated society, and they think it might be something to do with that. But it's kind of weird. It's very high in Nebraska for some reason. To work in Nebraska, Parkinson's is way more prevalent there than other places. Maybe again it's agricultural use. We don't really know. Those of us who've got darker hair are going to have less chance of getting it than the blondes in the audience. If you're a redhead, you may have to give up now. I think blondes have got a 60% more chance more than dark-haired people to get it. And if you're a redhead, you've got 3 times more likelihood of getting Parkinson's than a person with brown hair. If you've got red hair, you're more likely, 3 times more likely to get Parkinson's than somebody who's got dark brown hair. Why is that? What thing dies when you get Parkinson's? Substantia nigra. Substantia nigra, the black substance that makes dopamine. Also, so basically the production of dopamine is very similar in process to the production of melanin. The thing that gives skin color and hair color, melanin. And there's a link between your ability to produce melanin, or the way you produce melanin, with blonde hair, red hair, black hair, versus production of dopamine. They think there's a link, obviously, between hair color and Parkinson's disease. So if you're redhead, go and dye your hair. Unfortunately, that wouldn't work. That might have hair. Here's a bottle of hair dye. That's a treatment for Parkinson's disease. I wish that would work. Unfortunately, it doesn't. So again, unknown etiology. We don't know why it starts to degenerate. The rate of concordance is about 5%, which is, what does that mean? Rate of concordance is 5%.
If you have a twin, you have it.
You're an identical twin. What's the chance of your identical twin having it if you have it? Like MS is like 25% rate of concordance. Schizophrenia is 60%. So there's somewhat of a genetic link there. Anyway, we get these symptoms, right? When we all know these symptoms. Bradykinesia, would that be a positive or negative sign? Negative. They're slower movements. They're slower than normal. Something's been taken away from them, as it were. Akinesia, negative, obviously. This resting mask-like face, right? They go very featureless. They don't smile. Everything's very blank. Pill-rolling tremor, positive or negative? Positive, obviously. Hypertonia, cogwheel rigidity, where you try to stretch the arm and you go dip, click, 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 like that. Very, very interesting. It's obvious when you see it. When you first, you hear about it, when you first feel it on a patient, it's unmistakable what that cogwheel rigidity is. Stoop posture, micrographia, small writing, gait dyskinesias, shuffling, small steps, fascination where they hurry up, retropulsion where they go backwards, pedal turning often result in retropulsion. So retropulsion only pedal turning and doing this, right? I've got a video of that in a minute, I think. And they might start walking backwards. Or another way what will generate pedal turning is reaching up to pick something out of a cabinet in the kitchen. So they'll open a cabinet, reach up a can of beans, and they'll start walking backwards like that. When everything starts to grab, the gravity goes backwards and they can't catch themselves, they'll take 4 or 5 steps backwards. And they also, it's often forgotten though, they do have emotional and cognitive deficits, which are often ignored because the symptoms are so obvious, the other things, the dyskinesias, the other stuff. This pill-rolling tremor is about 3 to 5 hertz, I think I mentioned. So 3 to 5 times per second they'll be doing this pill-rolling tremor. Treatment, what have I got? I've got a picture of that. Okay, here's a lady with Parkinson's disease. Let's see if this will work. What? So I've worked a lot, I'll maybe show the video in a minute. I've done a lot of work with Parkinson's gait. Did some experiments and found how to help it. Here's a bloke from England. Off phase versus on phase. On dopamine therapy. Can you hear that? In back garden, England. This is off meds. You're on and off phase. This is off phase. Because pedal turning. He's free to stick to the ground. You can't get that foot off the ground.
Second trip where you get the same patient about 30 minutes later after he's taken the L-dopamine medication.
30 minutes after he's had his dopamine, this is him now walking.
If you look closely, it also demonstrates some normal dyskinesia with his head and neck. His head wobbles a little bit from side to side.
Same bloke. But half an hour later, amazing, right? That's what dopamine does for somebody. That's what L-dopa has done for him. Half an hour after, he's got the system, he's got L-dopamine. You can't give people dopamine. Why not? It won't cross the blood-brain barrier. So you give them a precursor of dopamine called L-dopa. Okay? L-dopa. Or levodopa. Same thing. L-dopa. now what you'll often see, they'll give them L-dopa combined with carbidopa. Carbidopa and that mixture, brand name would be called Cinemet often. You've heard of those drugs, Cinemet? So that is a combination of L-dopa and carbidopa. Carbidopa is a drug they'll give you that will prevent or try to stop the body metabolizing L-dopa except in the brain. So it binds with L-dopa and prevents other parts of the body using L-dopa because you want to save it for the brain. So carbidopa does not cross the blood-brain barrier. L-dopa does. So basically carbidopa breaks off from L-dopa, allows L-dopa to go into the brain and is used for these basal ganglia circuits. So carbidopa prevents L-dopa being eaten up, being metabolized by the rest of the body before it can get to the to the brain. Some treatment options. I say you go over these in other classes. It's not a clinical course, unfortunately. Dopamine replacement, obviously, there are many other drugs you can give as well. Cueing is a big thing. Before we talk about that, let's say rigidity is one of the cardinal signs. Remember, the cardinal sign of Parkinson's disease, one of them is rigidity, particularly late in the disease. So you're going to be working against that. You're trying to treat the rigidity of these patients, the stiffness, the muscles. So you want a lot of chest expansion. Everything gets smaller and they get crunched over and they huddle down. Everything gets smaller and smaller steps. Kyphotic posture. You can't walk normally with your such a kyphotic posture. So you're working on chest expansion. A lot of patterning. I think I mentioned in the motor control, we do a lot of kayaking with them. You get a kayak or paddle or sit on a stool and with a broomstick and they try to paddle a canoe and things like this. Try and get this rotation and the chest expansion. Cueing, very important. Instructional cueing. Like we've talked on it, OT has talked well about the think big, act big, talk big stuff. Shout. Tell them to shout at you. Take the biggest steps you can. Write big letters. Get away from this micrographia. Everything gets smaller and smaller. Fight that cognitively, and you can, to a certain extent, you can fight these deficits cognitively. Auditory cueing. Make a rhythm, music, dance, or just clap your hands. They will walk in time to that. Well, I said in the class we've got auditory metronome. Give an auditory metronome, put an earbud in, and you turn up beep, 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 and they'll walk in time to that. Increase their cadence. Works great. Spontaneous cueing, we might forget that, we won't get that. Visual cueing, I talked about motor control a lot, but very briefly, if you put lines on the floor, people can walk over them. You get this, remember the external cue to move is gone in these patients, or deficit anyway, deficient. So you put lines on the floor and a patient can step over those lines. Often they'll freeze in doorways and things like this. Freezing of gait is a very common occurrence in some of these patients. Very quickly, here's that little experiment we showed you in motor control. The OTs haven't seen this, but this is a lady I had here with Parkinson's disease. There's a typical gait coming in. She walked for a month up and down the gym floor. Didn't get any better. Extra walking didn't help her. Then I measured her gait, her step length, and I increased. I put lines on the floor, those blue lines there you can see. 110% of her baseline step length, half. And she walked right over them. Whoops. She walked over these 3 times a week for a month. Other people have done this type of cueing experiment, but they only did a one bout of cueing. They never looked at a long-term use of cueing. So we had this patient walk over these cues for a month and took the cues away. And she came into the lab and walked for a month after. Every 1 day, 2 days, 1 week, 2 weeks, 3 weeks, a month, whatever. And this is her 1 month after he took the cues away. A big improvement, I would say, yeah? And this is a comparison of those two. So this is the first, this is the baseline, and this is 1 month after he took the cues away, and there she is walking amazingly better by having these cues on the floor for a month. All the patients I see, Parkinson's disease, I put lines in there, I measure their gait, step length, increase it a little bit, and stick cues. I put masking tape on the floor of their carpet, in the kitchen, in the hallway, whatever, and they walk up and down these cues. The guy I had down the road there a while ago, he was homebound for 3 months. He was 3 or 4, 9 months I think it was. Can't walk around the park for 9 months. He lived 2 blocks off the park on Broadway here. He did this for 2-3 weeks, and he was walking around the park 2-3 blocks down and 2 blocks around the park, just by doing visual cueing. It's a very, very prominent way of driving gait by using visual cueing. Are we all finished or not? Alright. Next class we'll look at these signs, these issues as well in the basal ganglia. Question about Parkinson's disease. As therapists, you can make a big change in patients with Parkinson's disease. Unfortunately, though, you don't get them. The physician gives them drugs and sends them on their way. They don't ever consider occupational physical therapy. Rarely.